Welcome everyone to the Weathering Change month or April 14th seminar. Our speaker is Holly Essler from the University of Pennsylvania, and she'll be talking about neurology and the environment and epidemiological approach.
Okay, so everyone can see my slides. They look okay? All right.
Yep.
So thank you so much for having me. I'm really delighted to be here. My name is Holly Elser, and I'm finishing up my clinical training in behavioral neurology at Penn right now, but I'm also an epidemiologist by training. So I did my master's in public health and my PhD at Berkeley. And today's talk is actually sort of four seemingly disparate projects that I'm going to sort of take you through, but hopefully by the end, you'll see that they all sort of focus on the same general question that I've been really interested in ever since I was a medical student, which is how do climate and the environment impact diseases of the central nervous system? And more importantly, how do they impact patients with disorders of the central nervous system? And I want to just sort of briefly mention that I have no financial conflicts of interest to disclose before I jump into things. So the first the first project that I'm going to talk about focuses on the implications of anomalously warm weather for acute care visits in patients with multiple sclerosis or MS. And the first slide I'm going to show you is actually a photograph of the Palo Alto VA. And this photo is here to remind me to tell you that the idea for this paper actually came from a patient. So when I was a third-year medical student, I was sitting in a primary care clinic at the Palo Alto VA with a patient who had MS, and she had had MS for some time. She was wheelchair-bound by the time I met her. And in just talking to her about how she had been doing since her last doctor's visit, she mentioned to me, most of the time I feel really good, but when it's hot outside, my MS symptoms get worse. And this is actually well-recognized phenomenon in patients with MS. So heat sensitivity is seen in up to 80% of these patients. This is called Uthoff's phenomenon, and it is known that sudden increases in core body temperature in patients with MS can lead to what's called recrudescence. It's essentially the sort of reemergence of symptoms that were associated with prior disease flares. And the underlying mechanism is the transient slowing or blocking of neural conduction along previously demyelinated axons. A kind of fun fact from neurological history is that we used to try to diagnose patients with MS by tossing them in a bathtub full of very hot water, which is not done anymore. Now we use more civilized techniques like MRI and CSF. But regardless, this is something that is sort of known to be a feature of MS. And as you all are probably intimately familiar, as the global climate changes, weather and temperature are expected to become increasingly variable. The health implications of the extremes of temperature are well documented, particularly for certain vulnerable subgroups like patients with pre-existing cardiopulmonary disease, psychiatric illness, or dementia, as well as sort of economically marginalized individuals. But despite this, research that looks at the implications of weather and climate patterns for MS is pretty limited. And the way that I discovered this is after seeing this patient at the VA. I drove home and I did what any good scientist does, which is I Googled climate change in MS, and I found very little literature. And so because of this patient, I phoned up a couple of friends who I knew from graduate school with expertise in environmental science, environmental epidemiology, and the pathophysiology of MS, and we decided to work on this question together. And so what we did was we used this data set from the Optum Clinformatics Data Mart database. These are essentially de-identified commercial and Medicare Advantage claims database from a single private insurer in the US. And for this study, we used data from patients between the ages of 18 and 64 years old with follow-up from 2003 to 2017. And we were able to use a previously published and validated algorithm to identify patients with MS based on combinations of diagnostic codes and prescriptions for disease-modifying therapy. And the way that we constructed this study is the outcome of interest was a indicator variable, so 0 or 1 for every single month. That equaled 1 if there was an MS-related inpatient, emergency department, or outpatient visit, which were separate outcomes. And then the exposure of interest was this thing that we called anomalously warm weather. Um, and this phenomenon is something that I learned about from reading this paper that my friend and colleague Robbie Parks wrote in 2020 that focused on anomalously warm temperatures and injury-related deaths. And the construct of an anomaly acknowledges the fact that it's not just absolute temperature that may matter for health. Variability in temperature may also be consequential. And what he did in this paper is that he looked at instances where the temperature exceeded the long-term average for a given unit of geography to which individuals were otherwise acclimatized by at least 1.5 degrees Celsius. And he identified that as sort of an anomalously warm temperature. And so I was really intrigued by the idea that anomalies might matter for MS too. We kind of know from sort of years of studying the disease biology of MS that high temperatures matter, but maybe anomalies might matter as well. And so we used publicly available temperature at the zip code level, and then we created a monthly indicator variable for anomalies that equaled 1 if the local average temperature exceeded the long-term average by at least 1.5 degrees Celsius. And this 1.5 degrees Celsius threshold was selected to be consistent with Robbie's work, but also is sort of a nod to the Paris Agreement, which specified this 1.5 degrees Celsius threshold for warming, which I believe we've sort of comfortably exceeded by this point in time. And then our analysis was a generalized log linear model that we used to estimate risk ratios for the association between anomalies and these 3 sort of healthcare related outcome measures. And our models adjusted for sex, continuous age with a natural spline, I believe, as well as US state and calendar year to count for sort of geographic heterogeneity and secular trends, respectively. And so in this data set from about 75 million unique individuals, we identified about 106,000 persons with MS. In keeping with what's known about the sort of general epidemiology of multiple sclerosis, the majority were women between the ages of 36 and 55 years of age. And we found that anomalously warm weather was associated with increased risk for emergency department visits and inpatient visits, but less so for outpatient visits. And that's depicted here graphically. So from the left to right, you see the results for the study population overall, for women in the middle and men on the right, and you can see the associations for emergency department visits in green and inpatient hospitalizations in orange are stronger in magnitude. And this sort of, we can reason through this because if any of you have ever tried to make an appointment with a neurologist, you'll know that it probably took you several months of being on a wait list. You probably had to schedule it well in advance of the present day. And so you could imagine that emergency department visits and inpatient hospitalizations might be sort of more sensitive indicators of symptoms, whereas outpatient visits are probably sort of not scheduled in conjunction with the emergence of symptoms with any kind of close temporal linkage. We also did a subgroup analysis by age, and we saw that there were much stronger associations in older individuals. And again, that's depicted here graphically. So from left to right, along the x-axis, you can see the results for sort of successively older age bins, and you can see that the strongest associations are among persons ages 56 to 64 years old. And in all likelihood, what this reflects is sort of the accrual of disability associated with MS-related disease activity over time, the sort of occurrence of comorbid conditions that are known to be heat sensitive, like cardiopulmonary disease or something, some combination thereof. And there's an arrow to show you where those results are. So sort of tying this all together, I think my takeaway from this project was that these results underscore what is known, which is some patients may be uniquely susceptible to changes in weather and climate based on pre-existing conditions, and I think that probably includes MS. And I think our findings suggest that periods of anomalously warm weather may precipitate acute care visits in patients with multiple sclerosis. And I think, I'm not sure how frequently patients are counseled by their neurologist about the sort of potential role of environmental risk factors like heat, but I think that there is this potentially important role for providers to talk to patients with MS about, checking the weather before you go outside and making sure that you're not overdressed and likely to overheat if you're walking around and you're going to be active. There are some important limitations that I want to draw your attention to because no study is perfect. And I think here in particular, the use of healthcare encounters as the outcome is a fairly crude proxy for what we're actually interested in, which is symptoms. And claims data don't typically have direct measures of symptoms, disease burden, or disability. And I think studying sort of those more sensitive or disease-specific endpoints in conjunction with environmental risk factors is something that I would certainly be very interested in seeing. And the other thing I'll say is that the Optum data, which are proprietary claims data, lacked individual level sociodemographic characteristics. So we didn't have measures of race, ethnicity, educational attainment, income, or wealth, all of which could plausibly influence this association. And I think sort of bear studying in future research that focuses on the climate and multiple sclerosis. So that's sort of the end of study number one. Study number two, we're going to consider substantially different exposure and outcomes. So this is a project that I worked on sort of at the tail end of medical school that looked at metalworking fluid exposure and stroke mortality in US auto workers. And so I'll start by just sort of saying something that, again, I think many of you may know already, which is that air pollution is a fairly substantial contributor to the global burden of stroke. And this is something that's been known for some time. So early studies identified increases in stroke mortality following episodes of air pollution, including the Great London Fog of 1952. So another interesting part of sort of medical and epidemiologic history. And exposure to common air pollutants, including fine particulate matter, or PM, is associated with stroke incidence, hospitalizations, and mortality in the epidemiologic literature. But there's actually not a lot of research on occupational PM exposure and stroke. And this is likely a reflection of sort of data availability. So it's, for those of you who have any experience with occupational epidemiology, it's not common that you have both high quality measures of workplace related exposures and high quality measures of health outcomes. But I think occupational exposures are really important to study and to think about because they differ meaningfully from ambient exposures in their composition, the frequency and duration of exposure, and are typically experienced at sustained levels at substantially higher temperatures. So in this study, we were interested in understanding the implications of occupational metalworking fluid exposure for stroke mortality risk in a cohort of US auto workers. So for this data, we used, for this study, we used fairly unique data, which were occupational exposure histories from United Auto Workers General Motor employees that were linked with vital statistics data. So in other words, longitudinal work histories and exposure histories that were linked with cause of death. So the data included workers hired between 1938 and 1984 who were followed continuously through 1995. And then the outcome, which was available through this vital statistics linkage, was mortality due to ischemic stroke and intracerebral hemorrhage. And these were considered as separate outcomes because they differ in their sort of risk profile and pathophysiology. And the exposure was metalworking fluid exposure, estimated over time for each plant. There were 3 Michigan auto plants included in the data set. And then for each department and job based on personal and area level samples. For those of you who have experience in industrial hygiene or occupational epidemiology, you'll know this as a job exposure matrix or GEM, where you can essentially interpolate complete longitudinal exposure histories based on sort of a select number of measures for similar jobs or working characteristics. And I think you will all probably be familiar with fine particulate matter, but just so that we're all on the same page, this is a complex mixture of inhalable particles that are at least 2.5 microns in diameter or smaller. This size permits deposition with the alveoli, where they can translocate into the bloodstream. And then of particular interest for disorders of the central nervous system, the ultrafine fraction may directly translocate into the central nervous system, either through the olfactory bulb or across the blood-brain barrier from the bloodstream. Metalworking fluid is an important source of occupational PM exposure, and it's used to this day widely as a coolant or lubricant in machining operations, and current estimates are that roughly 1.2 million workers are exposed in the US. And in this study in particular, we were able to separately examine associations with straight metalworking fluid, which is a mineral oil-based fluid, soluble metalworking fluid, which is an oil emulsified in water, and then synthetic metalworking fluid, which has been used sort of increasingly over recent years in favor of the other two. And this is water-based and contains chemical lubricants, but no oil. And for our statistical method, we used Cox regression with attained age as the time scale, adjusting for race, sex, plant, calendar, and hire year. And this figure here just shows the median annual exposure over time of each of the metalworking fluid types. And this is by plant. So these are the 3 Michigan autoworking plants that are included. And what you can see is that around 1970, there is a drop-off in the sort of annual exposure to soluble metalworking fluid in particular. And this reflects sort of changes in regulatory practices with the establishment of OSHA. And then in this figure, you can see the result of our modeling for ischemic stroke mortality from left to right for straight, soluble, and synthetic metalworking fluid. And for each of these exposures, we created cut points or quartiles or tertiles based on the empiric distribution of the exposure in the data. And what you can see is that there are sort of strong associations for the highest category of exposure for straight metalworking fluid depicted with this purple arrow on the left, and particularly for synthetic metalworking fluid with this purple arrow on the right. And there are kind of null associations for soluble metalworking fluid. Here are the results for intracerebral hemorrhage. Again, from left to right, you see associations for straight, soluble, and synthetic metalworking fluid. And really, the results are rather imprecise here. So I don't think you can sort of convincingly argue in one way or another that there is an association with any metalworking fluid exposure because the confidence intervals are so wide. So, this study is, I think, parts historical and part occupational epidemiology, and we were able to leverage these sort of unique longitudinal exposure trajectories linked with vital statistics to ask this question about an occupational source of PM exposure and stroke mortality. And I think the way that I would summarize these findings is that there's some evidence that occupational metalworking fluid exposure, particularly synthetic metalworking fluid, is associated with ischemic stroke mortality. And this sort of specificity to this ischemic stroke outcome and to synthetic metalworking fluid is actually in keeping with a prior analysis of this study population that found that straight and synthetic metalworking fluid, but not soluble metalworking fluid, increased deaths due to ischemic heart disease. So you would imagine that there may be some sort of conserved underlying pathophysiologic mechanisms between ischemic heart disease and ischemic stroke. And similarly, there's some evidence from experimental studies and animal studies that exposure to particulate matter triggers prothrombotic physiologic changes that might increase your risk for ischemic stroke, but not necessarily hemorrhagic stroke, which is typically mediated by changes in blood pressure and sort of predisposing factors like the existence of a cerebral aneurysm. Again, this study has some important limitations. So there were only 227 stroke deaths in total, I think 114 ischemic stroke deaths and 113 hemorrhagic stroke deaths. And so this leads to wide 95% confidence interval ranges, many of which included the inferential null value. And then I think you have to ask with any occupational study whether the results could plausibly generalize to other occupational settings, contemporary occupational cohorts, or other geographic areas, because there may be sort of important differences in work practices and secular trends and exposure that are just not reflected in these data. But I want to put a plug in here for the importance of ongoing research that focuses on workplace exposures, because the intriguing thing about workplaces to me is that they're sort of well-defined, both sort of physically, but also in a regulatory sense, and they may be subject to regulatory or voluntary exposure limits to protect worker health. As a complete aside, there's also sort of like an interesting tradition of experimental studies in workplaces, mostly in the economics literature. And I think that is a real opportunity that the sort of environmental and occupational epidemiologists have missed. So I think there's always a need for good occupational epidemiology. So now, in keeping with the particulate matter theme, the third paper that I want to talk to you about is focused on wildfire smoke exposure and emergency department visits for headache. So I became interested in wildfire smoke as an exposure when I was living in Northern California as a medical student. As an East Coast native, I had never, been near a wildfire before, and the dramatic change in the air quality was something that I just wasn't prepared for. And this on the left here is a photo that I took at 3 o'clock in the afternoon in Palo Alto. And you can see that the sky is kind of dark and has this eerie orange tinge. And this was because of some sort of very strange meteorologic reaction between sort of the cloud cover that day and wildfire smoke from a nearby wildfire that was burning sort of up north of campus. So then I came to Philadelphia to do my clinical training. And one of the things that I was excited about was to leave behind this sort of like regular exposure to wildfire smoke. But I was mistaken. And in June of 2023, there were wildfires burning in Canada, and this led to pretty dramatic changes in the air quality all along the sort of Northeast, including in Philadelphia. So this is a photo I took at 6:40 in the morning walking in from my shift. And you can see again that the sky is really hazy and kind of has this orange tinge. And the point I'm making with these two photographs is that, this is something that populations are increasingly exposed to, even outside of wildfire endemic areas. So anthropogenic or man-made climate change is expected to produce increasingly frequent and intense wildfires in the Western US where they're endemic. But I would point you to this really nice work that's been done by Marshall Burke's group at Stanford that shows that there have been either stagnations or reversals in air quality gains made in most US states since the 1970s as a result of wildfires. So this is sort of an increasingly ubiquitous exposure. Smoke exposure from wildfires is, of course, a recognized health hazard. It's been previously associated with wide-ranging health outcomes, including all-cause mortality, respiratory events, hospitalizations in persons with cardiovascular disease, as well as adverse birth outcomes. And there are some differences between wildfire PM and ambient PM 2.5 that may have implications for health. These include, relatively higher concentrations of oxidative and pro-inflammatory compounds. Wildfire PM is produced at higher temperatures. It also has a smaller average particle size. I think there's also kind of an emerging interest in understanding how what's burning might lead to differences in chemical composition and have implications for health outcomes. And then short-term ambient PM 2.5 has been associated with headache outcomes, but no prior studies at the time that we did this work had examined the implications of exposure to wildfire-specific PM 2.5 for headache. So for this study, we used the same data we used in the MS study, actually. This is the Optum Clinformatics DataMart database, this time with follow-up through 2020. And we conducted a case crossover analysis of the associations between overall and wildfire-specific PM 2.5 and emergency department visits for headache. And we looked separately at emergency department visit diagnoses of migraine, tension-type headache, cluster headache, which is the most common trigeminal and autonomic cephalalgia, as well as sort of other primary headache disorders or headache disorders not otherwise specified. And the way that we constructed these data is that for each headache visit, we selected up to 4 control dates that were matched on calendar year, calendar month, and day of week to address secular trends, seasonality, and day of week effects in treatment seeking. And this is sort of a stylized depiction of how a case crossover design is set up. So you have your emergency department visit, and then you select these up to 4 control dates within that month for the same year. And these are all going to be on the same day of the week. So if I went to the emergency department visit on the second Tuesday in March, every other Tuesday in March would serve as a control date. And then you compare the distribution of the exposure in the period immediately prior to the ED visit to the distribution of the exposure in the periods immediately prior to the control dates. And what's neat about this design is it's actually a case-only design, and because individuals are serving as their own controls, you hold invariant time invariant characteristics that could confound the association. So all person and place-based characteristics that don't vary over time can't confound the association of interest. And epidemiologists love nothing more than controlling for confounding. So I really love this design. Um, and the exposure of interest was the 7-day overall and wildfire-specific PM2.5 concentration assigned at the level of the 5-digit zip and scaled to reflect a 10 microgram per meter cube increase. I want to pause here and just note that this is a huge contrast, 10 micrograms per meter cubed. I had not done a lot of work previously with PM2.5, and I kind of picked this because 10 is a nice round number. I think if I could go back and do it again, I might have looked at a 1 microgram per meter cube increase or like an interquartile range microgram per meter cubed increase. But these are linear models, so you can just imagine dividing the odds ratio by 10, and that would be the association that you would see. But 10 is an enormous change in wildfire concentration or ambient PM2.5 concentration. So just wanted to throw that out there. I've learned since then. And then the standard analytic approach for a case crossover analysis is a conditional logistic regression. And this figure here depicts the distribution of wildfire-specific PM on the left and overall PM on the right across the state of California by zip code. And the thing that I would draw your attention to is that the concentration of wildfire-specific PM is sort of highest in Northern California, sort of around Humboldt County, if you're familiar with the state. Whereas for overall PM, you really see an intensification of the concentration in the sort of greater LA metropolitan area, and that almost certainly reflects traffic-related air pollution. And so among just shy of 10,000 unique individuals, there were 13,600 emergency department visits for primary headache disorders. Migraine was the most frequently diagnosed headache, followed by other primary headache disorder. And then the odds of an ED visit for any primary headache disorder increased by about 17% for each 10 microgram per meter cubed increase in wildfire PM2.5. And by subtype, we saw increased odds of tension type headache, other primary headache disorders, and cluster headache. Some of these are imprecise, as evidenced by sort of wider confidence intervals that include the inferential null value. But I think the odds ratios are large enough in magnitude that I'm confident that this is real signal. And then overall PM2.5 was associated with tension type headache, but not migraine, cluster, or other primary headaches. And that's depicted here graphically. So the things that I would draw your attention to is that the associations are stronger in magnitude across headache disorders for wildfire-specific PM2.5 exposure, but the confidence intervals are wider. And some of this, I think, probably just reflects the distribution of wildfire PM2.5. So ambient PM2.5 tends to have sort of a much narrower range of concentrations and is sort of steadily within that range over time. Whereas for wildfire PM2.5, the exposure is 0 on most days. And then, so it's like super, super zero inflated. And then there's a very, very long right tail where there is this extremely wide range of potential exposure levels. And I think that that just introduces some lack of precision into statistical modeling. So I think the way that I would put this all together is that although imprecise, these results suggest that short-term wildfire PM exposure may be associated with emergency department visits for headache. Associations were consistently stronger for wildfire-specific PM2.5, and we saw some differences across headache disorders. But I think there is an ongoing need for research into the effects of wildfire exposure for headache, and there are a ton of challenges associated with the study of headache and the environment more broadly. I worked on this narrative review with some colleagues of mine at Penn, Hopkins, and the University of Washington. And we sort of dig into the recent literature and highlight some of the challenges related to studying headache, one of which is that, administrative claims are going to they're going to capture people who go to the emergency department, who go to the doctor all the time, who are prescribed medications, but headaches are highly prevalent at the population level, and lots of people with headaches never go to the doctor and certainly don't go to the emergency room. So how you sort of construct your outcome is really challenging. Similarly, headaches like asthma are episodic in nature, and you have to be really thoughtful about whether or not you're interested in the incidence of headaches, so new diagnoses of a headache disorder, or headache exacerbations or episodes. Perhaps the latter is going to be harder to characterize because of, again, inconsistent treatment seeking if you're using claims. And then I think it's also worth saying, and this is sort of an embellishment of a point I think I've kind of made already, that emergency department visits are going to systematically capture persons with more severe headache. And I also think that diagnoses of headache subtypes in the emergency department are probably not that reliable. And that's underscored by the fact that the second most common diagnosis was other primary headache disorder. So again, just sort of underlining the challenges of thinking about headache. And so to continue this theme of talking about wildfire smoke exposure, the last project I'm going to bring you through was a fairly recent analysis we did looking at wildfire smoke exposure and incident dementia. And as a behavioral epidemiologist, this is something that's really of great interest to me. So I'll start by saying that long-term exposure to ambient PM2.5 is an established dementia risk factor. It's noted as one of the sort of modifiable dementia risk factors in the 2024 Lancet Commission on Dementia Prevention. And there's a really nice recent meta-analysis from Mark Weisskopf at Harvard that shows that sort of if you meta-analyze all of the existing literature, we expect a 4% increase in the odds of dementia diagnoses for every 2 microgram per meter cubed increase in the long-term average of PM exposure. And while wildfires are a dominant PM2.5 source in California, particularly in recent years, it's just unknown whether wildfire PM2.5 exposure confers similar dementia risk. And so this study focuses on the implications of long-term wildfire and non-wildfire PM2.5 exposure for dementia in Southern Californians. And this was a study we conducted using Kaiser data. So this is electronic health records data. It's a little bit more rich, more detailed than claims data. And we included KPSC members aged 60 years and older. If you're not familiar with Kaiser, this is a managed care consortium, meaning the insurer and the provider are kind of one and the same, and it serves about 4.7 million people across 10 counties in Southern California. Notably, the Kaiser population is highly representative of its catchment. It has limited representation at the sort of extremes of the earnings distribution, but otherwise, the Kaiser patient base looks a lot like the counties from which they are derived. And then the outcome of interest in this study was all-cause dementia diagnoses identified using diagnostic codes. The exposure was long-term wildfire and non-wildfire PM2.5 concentrations, which we defined as the 3-year rolling average that was updated quarterly. So for each person quarter, there was a new estimate of the wildfire and non-wildfire PM2.5 concentration based on their geographic location. And we were able to identify time-varying location based on residential address and electronic medical records. And then we used a discrete time approach with pooled logistic regression. This is a survival analysis technique, but unlike Cox models, which assume continuous follow-up, this assumes discrete follow-up. And we estimated the odds of a new dementia diagnosis for each 1 microgram per meter cubed increase in this 3-year mean wildfire and non-wildfire PM2.5 concentration. And the models were all adjusted for age, sex, race and ethnicity, marital status, smoking, calendar year, and then census tract characteristics. We did some secondary analyses by age, area level inequality, and race ethnicity as well. And so among 1.2 million Kaiser members who were included in this study, about 75,000 were diagnosed with dementia over follow-up. This figure again shows the mean census tract level wildfire and non-wildfire PM2.5 concentrations. And again, you see that there are some differences in the distribution of exposure with sort of a concentration of non-wildfire PM2.5 around Los Angeles, again, probably reflecting traffic. And the other thing I want to draw your attention to is that the sort of range of average values is higher for ambient PM2.5 than it is for wildfire PM2.5, which again reflects the fact that most days there is no wildfire smoke, but then it can have this sort of incredible range and can spike at very high concentrations. And we found that for non-wildfire PM2.5, there was a 1% increase in the odds of dementia for each unit increase in the 3-year mean. And again, I think that this sort of magnitude of association is sort of in keeping with what the prior literature has shown, thinking back to that odds ratio of 1.04 from the meta-analysis that I mentioned earlier. But for wildfire PM, we saw a 12% increase in the odds of dementia, which is an enormous magnitude of association in my mind. And we also saw some really, I think, meaningful subgroup heterogeneity. So on the left, you see these results by age. So we saw a much stronger association for wildfire PM2.5 among persons who were less than 75 years of age when they enrolled in the study. And I think that this probably reflects a lower baseline risk of dementia in this age group and probably fewer competing risks. And then we also saw a stronger association in high poverty census tracts. And then by race and ethnicity, we saw stronger associations for non-white racial and ethnic patient subpopulations, with the strongest magnitude of association for persons who are identified as belonging to the other racial and ethnic category. And I want to just sort of acknowledge who is included in this category, because I think this is a group that is often not discussed in the epidemiologic literature, but this includes persons of multiple races, Native American and Alaskan Natives, Pacific Islanders, persons who identify as belonging to a different race and ethnicity or who have unknown race and ethnicity. And so this group actually does include some highly marginalized subgroups by race and ethnicity. And that you see such a strong association in this group, I think, underscores that environmental risk factors have to be considered in the context of individual and area level social stratification. So this study suggests that long-term exposure to wildfire and non-wildfire PM2.5 are associated with dementia, but there's a much stronger association for wildfire PM2.5. And I find myself wondering why. One reason is related to possibly systematic differences in the actual exposure. So wildfire PM, again, is generated at higher temperatures, has higher concentrations of oxidative and pro-inflammatory compounds, and has a smaller average particle size. Maybe these factors collectively increase its sort of hazardous nature. Another thing that I think you have to contemplate when you're thinking about dementia is that that there may be unmasking of existing disease in persons who probably already have underlying Alzheimer's disease or another dementia, but are able to sort of compensate within the constraints of their daily routine. But if it's disrupted by a wildfire event, maybe that leads to the unmasking of symptoms earlier. Another thing that I think is important to acknowledge is that, as I've mentioned previously, the sort of chronicity and intensity of the exposure differs meaningfully between wildfire and non-wildfire PM2.5. And it's really not clear what these intermittent spikes in exposure mean for a sort of neurodegenerative condition like dementia that develops over a several years period. There's some really nice work by my colleague, Joan Casey, who's at the University of Washington, that aims to sort of identify how you could capture the chronicity of wildfire smoke exposure over longer periods of time, but this is certainly an evolving area of research. And so I'll wrap up by saying that this risk was also much more pronounced among minoritized patient subgroups and those living in high poverty census tracts. This is sort of in keeping with a long tradition of thinking about environmental justice. So in the US, we know that environmental exposures disproportionately impact racialized and economically marginalized persons and communities who may have constrained economic choices that limit behavioral adaptations. And they may also have enhanced physiologic responses to environmental exposures that reflect worse baseline health, the cumulative effects of discrimination or chronic exposure to psychosocial stressor. And so I think that, oops, sorry guys, continued study of wildfire PM 2.5 has to consider differential health risks within subpopulations and the mechanisms that underlie those differences, because getting a grasp on how the effects of wildfire smoke exposure differs within populations and what drives those differences is, I think, sort of essential to advancing health equity in the context of a changing climate. And so now taking a step back and wrapping all of it together, these 4 very different projects, I think, as a clinician, I come at this thinking that understanding how our patients are vulnerable to the environment is essential. But I think there's also so much that remains unknown about how the ambient environment contributes to the onset and worsening of neurologic disorders. There are lots and lots of neurologic disorders that remain relatively underexplored. I think the duration and chronicity exposure is an active area of research. For air pollution, there are sort of persistent questions about whether the origin and composition of particles matters for health, and if we have sort of sufficient limit of resolution to study that. And then I think, as a medical student, as a resident, as a fellow, I've relied mostly on existing sources of data, which includes claims data, which can empower you to study very large populations, but those are really crude ways of operationalizing disease outcomes. So are there ways that we can improve the way that our outcomes are measured? I would also say that, I probably don't need to make too much of a point here to this audience, but everyone is exposed to the environment. So the ubiquity of these exposures kind of can't be minimized. And then I think, sort of hearkening back to the points I made a few moments ago, these questions should, whenever possible, be considered in the context of social stratification and disadvantage, because identifying patient subgroups that are particularly susceptible or vulnerable helps to mobilize resources. And then I think another sort of interesting but also sort of worrisome note is that as the climate changes, so too will the relevant questions. So the exposures that are most timely and most worthy of study may be somewhat of a moving target as time moves on. And with that, I want to acknowledge the numerous people across various institutions that I worked with on these 4 projects. I'm lucky that epidemiology is really a team sport, and I have tremendous collaborators whose expertise I rely on heavily, as well as funding from the NIH, from NIEHS, from NIDA, from NIOSH, and from NIA. And with that, I want to thank you for your time and attention. We'll wrap up a little bit early. We have plenty of time for questions. And I thank you for listening to me.
Well, thank you very much. I found that very enlightening, but disturbing in many levels.
Yeah.
So, but yeah, thank you. Does anyone have any questions?
This is Ardith Morrow. I'm an epidemiologist here at the University of Cincinnati and division director of Epi. I just want to admire you for a minute. I'm going to say that you are very rigorous in your epidemiology, and it's really beautiful to see the methodologies that you've applied, to these questions, and also the breadth of the different outcomes. So I'm, as an epidemiologist to an epidemiologist, let me just ask you, what, something of, given the fact that you're using the most rigorous approaches you can that are available at this time, right? What kind of pushback do you get, or what kind of questions are you getting from different audiences? Particularly in the, so there's those of us who are inclined to see both the rigor and the importance, and inclined to believe the results. And then there are people who are more maybe less inclined to, and in the public domain as well, whether you're finding people kind of generally accepting and interested, or are you finding a lot of pushback. There's more a marketing question than it is an epi question.
Yeah. Well, what I will say in defense of my clinical colleagues, I have actually found that there is a lot of interest in the implications of the environment for neurologic diseases. And so what I typically do if I'm studying a disease that isn't one that I sort of interact with on a day-to-day basis in the clinic is that I involve an expert in that disease. And I've had plenty of sort of pure clinical colleagues who have been really enthusiastic about helping to sort of make sure we're taking care of the outcome. So I've actually been very pleasantly surprised by how receptive people are to this work. I will also say that on the clinical side of things as well, I think our sort of major academic societies within neurology have really embraced this idea that the environment matters for our patients. So I may be just fortunate to be sort of operating in a discipline that is like somewhat forward thinking on this issue. But I think just generally that bringing the clinicians into the fold can be really powerful because then you know that you're taking care of the outcome and you can sort of make sure that you're framing your messaging in a way that's going to fly with the clinical audience.
Very true. Yeah. I love the fact that you called epidemiology a team sport. I totally agree with you. It should be multidisciplinary, right?
Yeah.
And you've made sure that it is in your hands. One of the things you're talking to a Midwestern audience. And so we do experience, for example, wildfire here. We've been addressing some of that, but it's periodic. And against a background of fairly, as you noted, higher PM 2.5 levels than we had enjoyed for a while. We got better and then we got worse again, right?
Yeah.
So I don't know. This is one of the things about studying the same thing in different areas. You're in a more, I would call it, endemic area for wildfire. And we're in a more periodic, exposure situation. But it would be nice to, learn from your methodology and try to see what we can apply here. But it would kind of be much more targeted periods.
I will say that there are, from the Stanford Echo Lab, which is Marshall Burke's group, there are national wildfire PM 2.5 estimates from, I think, 2006 to 2023. So those data certainly exist, and you could sort of look at, I think just starting by sort of like characterizing what the chronicity of exposure looks like, and what the sort of range of exposures is in the sort of Midwest and around Ohio could be really valuable, because I think there is a lot of sort of descriptive work that can help sort of move the conversation along, because I bet if you asked most people in the Midwest if they're exposed to wildfire smoke, they'd say no or very rarely. But if you sort of look at the empiric data, I think you'll see that maybe there are more days than you would expect where there are low levels of exposure because of wildfires burning elsewhere.
Right. There's certain periods where everybody knows they're being exposed because it's really
definitely
bad. But it's
well, the funny thing is that going from Northern California to Philadelphia, when we had those Canadian wildfires, there were people outside like going for their morning run, and nobody would ever do that in Northern California. And I realized that like the behavioral adaptations are so much more natural in a place where wildfires are endemic, and maybe people in the Northeast aren't used to like skipping their run on the day that the air quality index is 200, for example.
Yeah, but you're right, having planned in advance how they're going to handle certain conditions, right?
Yeah.
Well, I think I'm hogging your time here, but I wanted to say, it was a lovely talk and really exemplary work. And we're excited about the fact that you were here today talking.
Thank you so much.
Thank you.
So the one question I have, because the occupational side of things is really a big part of my interest, and I do occupational ergonomics and have really delved into with the climate of the exposures to the occupations. Which with your different research, which occupations do you think are most applicable to this?
It's a great
obviously
question.
You had very specific ones, but what are the broader ones that are probably more applicable?
I think that it's sort of manufacturing is the sort of general category that comes to mind for me. Any place where there is any kind of machining going on, and maybe also sort of like logging and forestry, where you might have a lot of sort of particulate wood dust exposure. But those are the occupations where I think you're likely to have sort of sustained high levels of PM exposure. The other thing that I think about with temperature is agricultural workers. And so sort of as there are secular trends in climate and the environment, those working populations are going to be much more highly exposed and much less able to make behavioral adaptations. So those are sort of like the two buckets that I think are the most intriguing. And certainly there's a lot of really nice work that's gone on in the Central Valley of California looking at pesticide exposure as well in agricultural workers. But my dissertation advisor is an occupational epidemiologist who worked primarily with auto workers, miners who were exposed to both silica and diesel exhaust, and then we had for some time data from Alcoa, the aluminum company of America. So those were sort of fabricators, smelters, pot room tenders, and all of these working populations have very high sort of sustained PM 2.5 level exposures.
Yeah, so one of the groups, yeah, as I said, we are doing occupational, and I focus on that. We have a study we're starting right now for landscapers. I think that's another one.
Oh, yeah.
We're actually measuring the particulate that they're exposed to when they're lawn mowing and as well as chopping up trees. It's going to be a broad breadth of activities to see how that explains, and looking at it in low temperature or regular temperature in the spring versus a high temperature in the summers. And so we're doing that. I think, another key place that I have a real passion for is the people that are coming in to recover and refurbish for after major events. For example, after the events of a tornado, I think that these type of events that are occurring more rapidly, especially in the state of Ohio, as the tornado alley is shifting to the east. There's also the avenues that I think you're when you get a old farmhouse that is that is demolished or whatever, you're going to get very different particulate, lead paint, asbestos, many things that we know are very cancerous already, and or very detrimental, other heavy metals. And then you come in, and then black molds obviously is another huge issue when you have water, and all these types of things will get aerosolized when you go in and remove it and tear it down from the rest of it. So I think this is something that'll happen a lot more in the environments that we're seeing. So that I think is very applicable to what you're presenting.
Yeah. And I think, again, to the points I made about sort of like working conditions and workplaces maybe being sort of more well-defined and more maybe sort of clearly modifiable, I think that the first step is always sort of identifying the problem, and then hopefully you have an employer or workplace where there can be sort of positive regulatory steps made to protect worker health.
Yep. Well, thank you very much. Is there anybody else that have any question? I don't think so, but thank you very much. I really enjoyed this conversation as well as the talk, and good luck in your research. It's exciting and needs to be done. So
thank you so much. Thank you so much for having me, and have a good afternoon.
All right. Thank you. Bye.
Bye.